I think having medical students and residents would be a very significant and important thing to do. And I think it serves a number of purposes. One, I think as we try and build training programs and transfer skills, I think certainly residents and senior residents, I think, have a role to play in being able to help with that. And I think, even a resident that's training here in urology or general surgery, who goes and does a rotation overseas, I think there's real value in that, even if they don't want to ever go and work in a global health environment again. And I think what it does is it teaches you to think and make decisions without necessarily having to be, in terms of being out of your comfort zone. And so I think sometimes being exposed to what people can manage, what people can live with, making decisions that you may not necessarily make here, but because you don't have the piece of equipment you normally would, you may choose to treat something conservatively. So this idea of reinforcing this concept of avoiding harm, I think it actually is a good exercise to go through. I think what you realize when you go through medicine and surgery is you'll never see everything. There's always something new you're going to see, and even here there's always a complication that you may not have seen before, and all you can do is draw on your experience. The common things we see in Malawi are not that different than what we see here. We see men with voiding dysfunction. We see advanced prostate cancer. The one big thing that's different that I've seen in that part of Africa that I don't see here is a different kind of bladder cancer. And so bladder cancer in the developed world is essentially an occupational or smoking related disease. It's a transitional cell carcinoma. And in that part of the world, it is really a complication of infectious disease. It's really a complication of schistosomiasis, which is a parasite, as we know, and is endemic in that part of the world. And so with squamous cell carcinoma, which is something that I may have seen once or twice, a few times over the years in 22 years of practice here, and is usually due to other forms of chronic inflammation. You only read about schistosomiasis primarily when you're working to prepare for our exams here. And so something that I may have seen once in 22 years, and somebody who had a travel history and had spent significant time in Africa. My first trip to Malawi in June of a couple of years ago when I was there was I think I saw probably 8 schistosomiasis bladder cancer patients in a 2-week span, and so that's eye-opening at many levels, right? It's a completely different disease process, but it speaks to really a public health issue, right? So even though the impact is and the consequence is surgical, it is rooted in the fundamental issue is how do you address that at a public health level, right? In terms of prevention and if you're and finding these people, how do you implement praziquantel appropriately as a prophylactic dose? So it's pretty shocking, right, that it would be something completely different, and but very much a common thing, an endemic thing, I would say. We can't solve everything, and sometimes my role and my goal is to ensure there's nothing meaningful or significant that needs to be uncovered and managed. So I brought that perspective, I think, a little bit. I think on a process in the OR side, we complain, I think, about a lot of issues with in our own healthcare system. It's challenged, it's not probably resourced. It isn't resourced to the extent that we would like to do it. You learn to manage. I think we're still doing pretty good. So it's sort of reinforced. Notwithstanding, I think we do need to resource and look at our system a little bit better. But it has taught me maybe to appreciate that a little bit more as well.